So I'm gonna give an overview of chimeric antigen receptor modified T cells for B-cell non-Hodgkin lymphoma, a follow-on to a lot of what Dr. Maloney presented this morning and some of his center's data as well. Here are the disclosures again. So by way of outline, CAR-19 clinical data in chemorefractory patients with B-cell non-Hodgkin lymphoma, predominantly diffuse large B-cell lymphoma. I'm going to go through a UPenn study that's in phase 2 and was last presented at ASH last year, as well as the NCI update from Dr. Kokendorfer that was presented at ASCO 2016 with some interesting correlative T-cell persistent and cytokine data. I'm going to go through our 12117, which is CAR-19 with the 28 zeta construct post-auto transplant, and then we'll go through some summary slides. So by way of one slide, there are essentially 3 generations of CAR-modified T cells. The first generation just consisted of a functional T cell receptor intracellular domain linked to an scFv that did not show much persistence or activity in animal models. The second generation construct in the middle, which integrates a co-stimulatory molecule, either CD28 or 41BB, is the predominant modality being studied both in ALL as well as B-cell non-Hodgkin lymphoma, and we're going to begin to see later generation, third generation products with secondary co-stimulatory molecules or cytokine inserts. And you can see the centers underneath each with variability in terms of retroviral transfection with either lentivirus or retrovirus or lentivirus, as well as a transposase-based Sleeping Beauty modality used at MD Anderson. So this is the phase 2 study for relapsed refractory 19 positive patients from the University of Pennsylvania. Stephen Schuster is the PI. This was presented at ASH. Essentially, relapsed refractory patients were eligible. Of interest in their study, it's dealer's choice in terms of quote-unquote cytoreductive therapy or conditioning. Patients are infused with CAR-modified T cells day 0, and then they have frequent follow-up. They will have updates at ASH this year that I have not seen, but I've been told, I think FL will be in an oral presentation. Basically, half the patients responded. They had a responder out over a year. Looking at these swimmer-type plots, the median follow-up was something around 6 months with some ongoing clinical responses. At the University of Pennsylvania, they sort of give a fixed dose and not per body weight. And here's some of the peak persistence data, typically 1 to 1.5 weeks post-reinfusion. Here are their grade 3, 4, 5 AEs that were possibly related. Of note, a grade 3 and a grade 4 cytokine release syndrome, an encephalopathic death, and 1 patient with delirium. They didn't report other neurotoxicity on this study. The NCI construct of interest to us is very similar to the Memorial construct with a 1928 zeta co-stimulatory molecule and transmembrane domain. The only difference is the scFv that recognizes CD19. Dr. Kokendorfer has probably published the most peer-reviewed data in manuscript form. They've gone through 2 sequential protocols with higher dose cyclophosphamide and fludarabine, and then a lower dose study. They initially presented their high dose cyclophosphamide, which is quite high dose cyclophosphamide in combination with fludarabine in 15 patients. Of note, they saw a majority of patients with a DLBCL and mediastinal large cell lymphoma, aggressive B-cell lymphoma with a response. But with the observation of nearly every patient demonstrated a grade 3 or greater non-hematologic toxicity, mostly related to fever, cytokine release syndrome, and neurotoxicity, their interim study was to lower the dose of cyclophosphamide, and this was recently updated at ASCO 2016. Dr. Kokendorfer was kind enough to let me borrow his slides. Basically, relapsed refractory large cell or B-cell lymphoma patients, 22 patients, 19 large cell, 2 FL, and 1 mantle cell lymphoma. They did follow a dose escalation scheme, as you can see below. The dose of cyclophosphamide was lowered from 60 to 120 mg per kg to a much more reasonable dose, and then within a week, the CAR-modified T cells were infused, very similar to our ALL experience here at MSKCC. This is very similar data to what Dr. Maloney demonstrated earlier. They actually looked at pre- and post-conditioning cytokines, including lymphoproliferative cytokines IL-15 and 7. They had a 41 cytokine panel, and he presented the significant values of delta from pre- and post-conditioning. So as expected, there is provision of lymphoproliferative cytokines, which is the idea behind conditioning to provide fuel for the cells. Of the 22 patients, 3 out of 4 patients responded. They had observed over 50% complete remission. I'm not sure if that's by functional imaging criteria. Of 19 large cell lymphoma patients, nearly half had a complete remission, and he's reporting that all the patients in CR have ongoing complete remissions, which looks like a median of 9-month follow-up. Both FL patients responded, and the mantle cell lymphoma patient responded. Summary of toxicity: every patient developed a fever. Grade 3/4 neurotoxicity was observed in greater than 50% of the patients, which is what we've seen in the post-auto setting, and I will show that data. There were a handful of patients that had hypotension grade 3/4, and there was complete reversibility of all toxicities as they're reporting. Peak levels of CAR-modified T cells associated with response, which is not surprising. This is demonstrated in these graphics. Also, toxicity, as Dr. Maloney presented this morning, was also correlated with response as well as response was associated with increased proliferation of T cells as well as toxicity as seen in the graphic above and below. And patients with peak levels of the lymphoproliferative cytokines IL-15 and IL-10 post-infusion, so that they analyze cytokines pre- and post-conditioning, and then post-conditioning and post-infusion, whatever's going on in that milieu, but it appears that patients with complete or partial remission or responding patients had increased levels of IL-15 that reached statistical significance, as well as the lymphostimulating IL-10. Same cytokines associated with neurotoxicity, grade 3/4 neurotoxicity with upregulation of IL-10 and 15, as well as granzyme B, and you can see the schematics here. So we recently closed this study to accrual, and we continue to follow patients. This is the 1928 zeta CAR-modified T cells post-high-dose therapy and autologous stem cell transplant. By way of background from earlier this morning, 2 large randomized studies with rituximab maintenance as well as radioimmunotherapy-based conditioning have not moved the bar from the original Parma study for autologous reinfusion of stem cells following high-dose conditioning. There's been no progress in 20 years. Perceived advantages of CAR-modified T cells post-ablative chemotherapy and stem cell transplant includes modulation of an immune suppressive tumor microenvironment, elimination of regulatory cellular elements such as myeloid-derived suppressor cells and regulatory T cells, elimination of cytokine sinks or provision of lymphoproliferative cytokines such as IL-15 and 7 that was demonstrated with the NCI group as well as the Hutch with Dr. Maloney this morning. And in the model of allogeneic transplant with donor lymphocyte infusions for relapsed disease, the standard would be to try to cytoreduce the disease so there's essentially less tumor volume to deal with. In retrospect, we don't know if this is the right model for this, and I'll get to that. We've identified patients, I presented this morning, and other groups that depth of remission to salvage therapy based on functional imaging is highly prognostic. Thus, we identified high-risk patients for the phase 1 study based on appropriate for an autologous transplant in adult patients that were chemosensitive to at least two cycles of salvage therapy, but remained PET positive by IHP criteria when the study was designed, or bone marrow involvement at the time of relapse refractory disease state, which has retrospectively been shown in small series to be very prognostic for poor outcome. Here's the schematic. The patients underwent 2 leukapheresis procedures, one for collection of CD34 positive stem cells, the second for essentially lymphopheresis and generation of CAR-modified T cells. It can't be overstated what kind of a juggle that is. In higher risk patients, they come in and get admitted to the hospital, get standard beam-based conditioning, day of rest, stem cell reinfusion day 0, standard pegfilgrastim support, and then split infusion of CAR-modified T cells that we've been doing since 2006 over 2 days immediately post day 2 and 3. These are the dose levels below per the dose escalation study. This is a table form of the 15 patients that have been treated on study. Of note, most patients with relapsed refractory large cell lymphoma that go to auto transplant have a median of 2 lines of therapy. That was our median, but nearly half the patients had 3 or greater lines, including upwards of 8. There's a lot of transformed histology, a CD5 positive large cell lymphoma, a patient with Burkitt lymphoma with residual disease by flow cytometry in the bone marrow at time of transplant, leukemic phase blastoid mantle cell lymphoma, a Richter's patient, and then some other standard garden variety diffuse large B-cell lymphoma and relapse refractory disease, although still chemosensitive at the time of transplant. Patient 12 here, this 45-year-old gentleman, received CAR-modified T cells at the University of Pennsylvania and NCI prior to this. Most notable in the phase 1 safety assessment was 10 to 15 patients demonstrated grade 3 or greater neurotoxicity. The vast majority of this was outside of typical hemodynamic insult associated with cytokine release syndrome. A lot of mental status changes, encephalopathy, aphasia is a common finding, seizure and seizure-like activity. Patient number 4 had a dose-limiting toxicity with severe cytokine release syndrome, intubation, acute renal failure. This was the only patient treated at dose level number 2, which is 1 times 10 to the 7th. As investigators, we reconvened, got cold feet, and went back to dose level number 1 and just expanded at that. Patient number 8 was an outside referral, relatively heavily pretreated, that had very slow neutrophil recovery and eventually developed a mucormycosis, which at our center we find is quite rare. More than half the patients received tocilizumab as initial therapy, mostly for neurotoxicity, and then half of them eventually received dexamethasone. So relatively toxic therapy to standard beam condition-based autologous stem cell transplant. This is the progression-free survival curve with a median follow-up of almost 1.5 years in the patients that are alive. Of note, there are 8 patients that have had progression of disease, 1 patient that had experienced non-relapse mortality. The first patient is actually going to undergo a biopsy shortly for a lymph node that's growing. 2 of the 8 patients have had CD19 negative relapses, which has been described most notably by the Penn group, may be associated with, or has been described to be associated with a variant of 19 that doesn't get expressed on the surface. So my summary of the initial experience is that it looks like in the relapse refractory disease setting, at least 50% of the patients respond. Durability of response still is to be determined with few patients out post 2 years or 1.5 years. Response to therapy typically correlates with toxicity, and we've seen that in our ALL population. I think it's going to be imperative in the relapse refractory population in later phase studies to analyze this data by intent to treat. Stephen Schuster at Penn actually is relatively forthcoming with how many patients that they can't actually get the CAR-modified T cells into. So the bias or potential bias here is that you're selecting patients that can wait 3, 4, 6 weeks to receive CAR-modified T cells while they're being made and receiving chemotherapy that's likely not disease active. We're questioning whether or not consolidation is a viable platform, and potentially the likelihood that there has to be some antigen on board. We took patients in following rituximab-containing salvage therapy with very low tumor volume, and the hypothesis is that we saw little expansion in our phase 1 based on those assumptions, and given beam conditioning, we think that we're adequately immune suppressing patients. Internally, we're currently enrolling on MSKCC 15295, which is the JCAR-17 CD4, CD8 1-to-1 central membrane T cells with the 4-1BB as developed at the Fred Hutchinson, and Leah Palumba's the PI of that study. Do I have time? I'm going pretty fast. So some thoughts on the spheres of CAR-modified T cell therapy. First, there's the product. Currently, second generation with variable co-stimulatory molecules, variable scFEs that recognize different portions of CD19, variability within the delivery system or vector, and then phenotype ratios and selecting certain immunophenotypic subsets of the effector cellular product is all variable all amongst all the centers. In next generation, there's many third generation constructs coming down the line, including a CD40 ligand and an IL-12 construct that's being developed here, as well as potential multi-antigen specificity to get around loss of tumor-associated antigen in selection following therapy. Dosing and timing has not, is a living product, and it appears that dosing and timing is not really relatable. There was a nice study from the NCI looking at CAR-modified T cells post-allogeneic transplant from allo donors, and they saw no association between peak CAR-T cells and the number of infused T cell dose. The clinical studies for adjunctive therapy in this platform are beginning. I believe that the University of Pennsylvania has a pembrolizumab study post-CAR-modified T cell infusion for non-Hodgkin lymphoma patients. Elegant experiments at the NCI demonstrate upregulation of exhaustion markers immediately post-infusion of the CAR-modified T cell product. There's ways to manipulate the microenvironment. Investigators looking at patients receiving CAR-modified T cells on ibrutinib, there appears to be skewing of Th1 type cytokines in the setting of ibrutinib and potentially enhanced expansion. Marcella Maus was a PI of one of the studies in Boston. So again, pharmacologic adjunctive therapy may be appropriate in this setting, along the lines also of the microenvironment, which hypothetically we're believing to potentially translate into our relatively disappointing outcomes on the phase 1 CAR-modified T cell post-auto-transplant study is the lack of B-cell antigen at the time of reinfusion. Again, this is the NCI post-allo study demonstrating that of responding patients, there was a correlation with expansion of CAR-modified T cells, and it appears that the patients that were more B-replete at the time of reinfusion, there were many CLL patients on that study with B-cell lymphocytosis. So it's sort of like a Goldilocks phenomenon. The more, you don't want the whatever, soup or bed or whatever, too hot or too cold, but you'd want it just right soup. Something about a bed, right? So it's sort of like a Goldilocks phenomenon. I don't want to mess with copyright, so I didn't insert any slides. David's probably familiar with this, that Michael Jensen's developing artificial antigen presentation vaccine strategies, which could be attractive to actually just provide antigen for expansion of T cells. And again, we're questioning whether or not the consolidative model is really the approach in minimal residual disease, at least in the lymphoma setting. I think ALL is a different animal, which goes to a few slides later. Dr. Mahoney showed these slides this morning. The addition of fludarabine appeared to dramatically increase the expansion and efficacy of the CAR-modified T cells. Whether that's a quantity or quality effect has yet to be elucidated, but the data is relatively compelling, and Cam Turtle presented this last year. So really it's kind of hitting on this Venn diagram that was made on a 12-hour flight to ASBMT without Wi-Fi. So and all the diseases are different. We know that immunologically CLL is a much different disease within the nodal stations compared to leukemic phase. ALL is a different disease to diffuse large B-cell lymphoma or more indolent histology B-cell non-Hodgkin lymphomas. So how these cells track, hone, work in the microenvironment is really, I think we're just kind of hitting the tip of the iceberg with this therapy. So the goal is to hit the target. Thank you again to everybody, my primary mentor, Craig Moskowitz, in whom this is an honor to, and Andy, you weren't here this morning, but I gave you kudos as well. I've learned so much from you all. And you being in clinic this morning represents, being in the Zelenitz and Moskowitz clinic, you see a lot of patients, which I try to take pride in to the current day. There's funding, and then our two big services with a lot of collaborators, and the CTC as well. Thanks to the physicians for providing slides, and the patients and family.